I do not want all clinicians to focus more on populations, but I do want 3,000 of them, and I'm going to tell you about the plan to make that happen. And I'm reminded when we started evidence-based medicine, an economist said that clinicians should be thinking about cost as well as evidence in the decisions. And we disagreed. We said that if you took streptokinase and TPA, it was not the job of the individual clinician to say, should I spend more money on this patient with streptokinase on TPA? That was something to be made at a population level. What the clinicians had to do was to get the door to needle time down and get the maximum benefit from streptokinase. Interesting, that economist, we asked him to come on a ward round, and eventually he came, and when the first patient had 4 diagnoses and 8 prescriptions, he said, well, I didn't realize it was also complicated, so he left. So we have to separate the population from the individual, but our plans, and I speak now from what's called the QUIP program, the Department of Health, are that 3,000 hospital clinicians and mental health clinicians will get population responsibilities. I'm not going to discuss general practice because that's been well covered. This Thursday, we're publishing the NHS Atlas of Variation. It's a tribute to Jack Benberg and the Dartmouth Atlas. And there are, as you might imagine, huge variations that have nothing to do with money, that do with organization, and huge variations in the proportion of the population in need that is being seen. The proportion of people getting TIA treatment within 24 hours, for example, is just well, it's no surprise, I'm sure, to anyone here. Now, what's the solution to this? What we're proposing is that there's about 3,000 clinical directorates in England. And they'd imagine you're Dr. Jones and you're a consultant lung physician in Brighton. Last year, you saw 500 patients, and you're terrific. You gave them all evidence-based care, patient-centered care, safe care, and you're part of quality assurance. But Dr. Jones, we would like you to think about how many people are there with respiratory disease in East Sussex. We'll give you a day a week to think about it and a support post. And we will do this as the 3 GP consortia in East Sussex. And even though we treat a lot of respiratory disease, you're in the knowledge business. You can concentrate full time on this. And we want you to do things like assure that patients have got good information. Train pharmacists in East Sussex about what they can do. Identify new GPs when they arrive in East Sussex and let them know what's happening. Localize the map of medicine for East Sussex for asthma and COPD. And we want you to produce an annual report on asthma and COPD for East Sussex. So we can compare that with the 105 other asthma services or COPD services in England. So that's what we would call population medicine. We've called it population medicine because the word public health gets such a bad press with hospital colleagues. There's no point in trying to interest them in that. The word epidemiology, there's no point in trying to interest most people in that. But we found population medicine really resonates well with clinicians. And of course, much of this happened before foundation trusts came along, when there were much better relationships between clinicians working in different parts of the network. But many of those relationships have been broken in the last 10 years. So the approach that, as we move to program budgeting, to the more explicit exploration of clinical differences, and this could be by population, frail elderly people, for example, and we focus healthcare not on health centers and hospitals, but on populations and health problems, then we see the need for most clinicians to carry on focusing primarily on the patient in front of them. I always say the morning surgery is one of the intellectual marvels of medicine. A GP said, you should see it in the afternoon when I'm getting tired. That's an intellectual marvel. So we want clinicians to focus on the consultation, but I do think that in every clinical directorate, I need at least one clinician. Needn't be a doctor. I've run it in screening with clinical scientists, but I need one person who's got a map on the wall and who's thinking about where the action isn't. Because so much of medicine is where the action is. My own definition of public health is to be where the action isn't. And I don't expect every hospital clinician to do that, but we're certainly looking at ways in which we would find, my estimate's about 3,000 for one for each clinical directorate to work with the local consortia. So, in summary, I don't want, how many doctors are there in England? thousands and thousands. I don't want them all to be more focused. They need to be aware, but I certainly want a subset of people in specialist service to have a different orientation and a different culture than they've got at the moment.